Well, good afternoon, everyone. It's really a pleasure to be here. I'm hoping this will be a little bit of a change of pace. I was listening to the last talk there. It was pretty intense. So maybe you can relax your brains a little bit here. I assure you I've taken certification and recertification exams now several times, and each time I've paid close attention to what are the topic areas and ethics that are covered, and I've really tried to tailor this so that it will be most relevant, very relevant for the exam, hopefully also relevant for your practice. The four topics that I'm going to cover are decision-making in the ICU, and then I'm going to talk about conflicts, rights to refuse treatment, and rights to demand treatment. Spend some time on ethical aspects of withdrawal of life-sustaining treatment, and then close with a case and some material about brain death and organ donation. So let's start with decision-making, and let's start right away with a case. So the case is a 77-year-old man who's admitted to the ICU following rupture of a cerebral aneurysm. After 2 weeks of ICU care, he is ventilator-dependent and inconsistently responds to simple commands like squeeze my hand. He lives alone and has no advance directive. He has a son in California with whom he has not communicated in 5 years, and he has several friends at the community center with whom he regularly socializes. So this is one of those accept-type questions. I'm saying depending upon state law, which varies a lot, each of the following may be acceptable except for one of these. A, the clinical team may make decisions for him using a best interest standard. B, the patient's son may make decisions for his father as the legally authorized surrogate. C, the clinical team may consult with the hospital ethics committee and the patient's friends to make decisions for him. Or D, the clinical team may seek appointment of a guardian ad litem for decision-making. So which one of those is not possibly correct? Okay, surprisingly you got that right. I sort of set that up as a really hard question because I think it is hard, and I'll explain why in a moment. But the correct answer is A, is that the answer that is not correct there is that the clinical team may make decisions for him using a best interest standard. And let's look a little bit about why. We know that an increasing number of Americans are dying in our intensive care units, and we know that now up to 90% of ICU deaths in some ICUs occur after a decision to withdraw life support, as opposed to a failed attempt to resuscitate the patient. So these are orchestrated deaths in our ICUs. But we have a real paradox here. Up to 95% of ICU patients are not capable of participating in this decision-making. So what's happening? Well, Doug White did a study of this, and at least in his study of patients who did not have decision-making capacity and did not have surrogates, 89% of decisions were made by physicians without institutional or judicial review. So this is being done, and it's being done a real lot. Now, you know, hopefully you remember from medical school ethics, if nothing else, there's two standards that we use for surrogate decision-making. One is the substituted judgment standard, trying to decide on the basis of what the patient would have decided if they'd been able to, versus the best interest standard, where we don't have any idea what the patient would have wanted. And under the substituted judgment standard, we have two choices, both of which are types of advance directives. So the first type is a durable power of attorney for health care, where the patient has designated somebody to make decisions on their behalf. And the second type are living wills. And one of the best known and most popular now is called the Polst form, which was developed by Susan Toll and Associates in Oregon and has now been adopted by many states. And I give it to you just as sort of a typical sort of advance directive document. It has 4 sections where the patient indicates their preferences for resuscitation, medical interventions from comfort measures to full treatment, use of antibiotics, and use of artificial fluid and nutrition. Now, if we don't have one of these, then we fall back on the best interest standard, and it is admittedly very vague. And it's often consistent with a wide range of possible treatment options. And I think this leads to something that is sometimes frustrating for intensivists, where you'll have two patients in the ICU who are really kind of medically identical, and yet on the basis of sort of best interest standards are being treated in very, very different ways. Sometimes one with very aggressive efforts at life support, and another will receive comfort measures only. So it's a complicated area. We often have trouble knowing who the surrogate is. 44 states have defined a legal hierarchy for designating the surrogate. So it varies in details, but this is a typical rank ordering from Wisconsin, beginning with the spouse, quite reasonably, and then working down, as you can see, to where close friends might be involved. Now, some states will allow physicians to make decisions based on previously expressed preferences of the patient. So if you've got that POLST form in front of you, many states will say you can act on the information on that form. But no state allows physicians to make decisions based on the physician's view of the patient's best interest. So when you have somebody without a surrogate, without an advance directive, who can't make decisions for themselves, in really no state are you allowed to make those decisions on the patient's behalf on your judgment, even though it is very commonly done, as the study by Doug White showed, 89% of decisions. And so that's why A is the correct answer here. And I put it out there for you as really perhaps we're an area where our clinical practice differs quite a bit from what is actually legally accepted practice. Now, there's only two empirical articles that I think are so well known and so often cited having to do with ethics and communication in the ICU that I think you ought to be familiar with them. So I'm going to mention them to you here. The first was this paper by Lutret in the New England Journal of Medicine a few years ago. It was a randomized controlled trial in France on the impact of proactive end-of-life conferences with families and informative brochures. So in the intervention group, there was a scripted conference around end-of-life that touched upon certain issues. And the intervention did result in longer family meetings, 30 minutes versus 20 minutes, but interestingly, most of that extra 10 minutes was taken up by the families talking rather than the physicians talking. And this has been shown now in a number of studies to correlate with improved family outcomes. The results that they achieved were somewhat spectacular. I think this obviously explains why this paper was published in the New England Journal of Medicine. You can see for yourselves there that they went back to these families afterwards and looked at post-traumatic stress, anxiety, and depression. And families did remarkably better when they were the beneficiaries of these family meetings. And so this gets frequently cited and is a paper that you ought to be at least passingly familiar with. The other one is a paper by Larry Schneiderman in JAMA about ethics consultation in the ICU. And this was also a randomized controlled trial that took place at 7 U.S. hospitals. And patients were randomized to receive either usual care or merely the offer of an ethics consult, which may or may not have occurred. Now, they found no difference in mortality, and that's very important. Because if having the ethics committee come in and talk to a family resulted in increased mortality in that group, we would be worried that maybe the family was being inappropriately persuaded to limit intensive care. So they didn't see that. That was the good thing. But what they did see was a very significant reduction in hospital days, ICU days, and days of ventilation. And so this study is often cited as really the only empirical evidence we have that ethics committee consultation in the ICU is not harmful and, in fact, is beneficial. So those are the two studies that I think you ought to be familiar with in this field. Okay, let's talk a little bit about how we manage conflicts in the ICU, rights to refuse treatment and rights to demand treatment. And we'll do this with case number 2. So this is a 40-year-old man who has a prosthetic aortic valve placed and who subsequently requires a pacemaker for third-degree heart block. He is poorly adherent to his anticoagulation regimen, and he suffers multiple embolic strokes over the next decade, leaving him unresponsive. His wife requests disabling of the pacemaker on grounds that the patient would not choose to continue living in this condition. So, which of these answers is correct? The pacemaker must be continued since internal treatments cannot be legally withdrawn. The pacemaker must be continued since stopping it would be euthanasia, would lead to his death, and would therefore be illegal. The pacemaker cannot be discontinued without a court order. The pacemaker may be discontinued as the wife is the patient's legal surrogate. Or the pacemaker must be continued, but the batteries can be allowed to expire without replacement. Okay, so that's great. Overwhelmingly, you've got the right answer here, which is the pacemaker may be discontinued. I think in the past 5, 6, 10 years maybe, this has become less controversial. But wasn't that long ago that it was widely regarded that pacemakers could not be discontinued. And let's talk a little bit more about that. These are really two sides of the same coin here, rights to refuse treatment and rights to demand treatment. And in the 1970s and 80s, the questions were really about the rights of patients and families to refuse medical treatment. And now that's come 180 degrees. And over the past 20 years, we've been dealing with the flip side, that is the rights of patients and families to demand medical treatment. So with regard to rights to refusal, at least legally, this has been pretty well resolved. We've had famous court cases, the Cruzan case in New Jersey about the right of a family to refuse mechanical ventilation, the Cruzan case at the U.S. Supreme Court about the rights to refuse tube feedings, and there's been now a very consistent pattern of legal cases that patients and families have a virtually unlimited right to refuse unwanted medical treatments. And this is not regarded as being euthanasia. This is not regarded as suicide. This is a privacy or a liberty right, depending on how it gets framed. And even if it means doing something silly that results in their death, if it's a considered and thoughtful decision, we have to respect that. And so that's why this is the correct answer, that the pacemaker may be discontinued as the wife is the patient's legal surrogate here. Now, the flip side, how about demands for futile treatment? Well, over and over again, in all sorts of documents, you will find it stated that physicians have no obligation to provide treatments that offer no benefit. That is, futile treatments. And this, I think it's probably the number one issue that we're seeing on ethics committees in hospitals around the country right now. And when it's not the number one issue, it's because clinicians have already learned that taking these cases to your ethics committee often doesn't do much good. The committee doesn't provide much that's helpful, and so you just quit coming to the ethics committee about them. It's turned out to be a major source of burnout among ICU clinicians, especially nurses. As the physicians, we can make rounds once or twice a day, check in, how's everything going. The nurses are there 12 hours a day and feel morally bereft, without support, and wondering what they're doing in the ICU. So it's a big problem. But it continues to be very difficult to solve. There's wide disagreement about what counts as futile. One thing I want you to know very clearly is that scoring systems, for example, Apache, are designed for populations and are highly accurate when applied to populations. But they cannot be used for individual prognostication. They are highly inaccurate in that regard. And something that I'm sure will be counterintuitive to many of you, but I think has been very well demonstrated in the literature, is that although we often talk about stopping futile care because we want to save money, every study that's looked at this has shown that stopping futile care will save a trivial amount of money. I know it's counterintuitive, don't have time to show you the data, but it's true. And I think part of the reason it's true is actually a credit to us. Most of the time when we say to families, it's not working, it's futile, we stop. It's that small number of cases, relatively small number, that stick in our memories, that sort of form a kind of a recall bias that I think makes us think this is a much bigger problem than it really is in terms of the finances. But in terms of morale in the ICU, I think it truly is a big issue. Now, the American Medical Association recommends a procedural approach to determining futility, including intensive efforts to reach consensus with the family, attempts to transfer the patient to other willing providers, getting ethics consultation, second opinion, and efforts at mediation. Nevertheless, despite all of this, rarely do we stop treatments without the permission of the family. And in fact, only in Texas are physicians provided with civil and criminal immunity for acting within these guidelines. Now, I've been very critical in my own work about the Texas law in many ways, but what I agree with is that I think that we're very unlikely to make progress with actually putting limits around some forms of life-sustaining treatments unless physicians can feel assured that they're going to have civil and criminal immunity about that. And I think this is an area where you're going to see more interest in the coming years as more states look to Texas for how to tackle this problem. Okay, let's turn to withdrawal of life-sustaining treatment. I think many of us went into intensive care medicine, perhaps a lot like surgeons. Many of us are surgeons, so the idea that we're much more interested in helping people live than in helping them die. And yet, as more and more Americans are dying in the intensive care unit, I think this is something that we need to own, perhaps more than we have in the past. I've sometimes thought it was helpful to think about end-of-life care in the same way we think about other procedures that must be learned and practiced, just like placing central lines, just like managing ECMO or doing an intubation. And a couple of things. One is you will always hear people say over and over about whether we are going to withdraw care on a patient. And I'd just like you to reflect for a minute how that sounds to a patient or their family members. Right? It sounds like abandonment, and I would encourage you to look at your language here. We never withdraw care. We always provide care. You might talk to people about withdrawing treatments, talk to them about withdrawing procedures, but don't talk to them about withdrawing care. It's the wrong message. Secondly, just like as with everything else in critical care medicine and throughout medicine, it seems, protocols and checklists are being increasingly utilized, and I think we're finding that they're very helpful at improving the quality of our end-of-life care. And just a couple of, I think, pointers that are often helpful is that when the goals of care transition from cure to comfort, at least in your head, if nothing else, think about rewriting all of the orders from scratch. And before you write an order or click it on the computer, ask yourself, will doing this actively contribute to the patient's comfort? And if the answer is no, don't put it down. And in particular, think about stuff that we usually regard as routine, such as x-rays, daily labs, vital signs, that sort of thing. I found that a useful exercise in helping us with palliative care in the ICU. Now, a very controversial issue has been the use of non-invasive mechanical ventilation, or BiPAP, in end-of-life care. And there was an SCCM task force a while back that I thought came up with this is a very useful recommendation. They said, if you're thinking about using BiPAP in an end-of-life setting, ask yourself, what's the goal of the treatment? And there's 3 possibilities. And I think if you get clear about the goal, it's very helpful. So first you're saying, well, we're going to use this as life support with no preset limitations. So we'll use it as best we can, and if we need more, we're going to go ahead and intubate the patient. So that's one. Number 2, we're going to use it in a situation where the patient or family have decided that they don't want endotracheal ventilation. So there we're going to use it as best we can, and if it's not enough, we're going to stop. That's it. And then third is where it's being used for a palliative indication. So we're going to use it, but not with an expectation of prolonging the patient's life. We're only going to use it to the extent that it makes the patient more comfortable. And where it's not, doesn't contribute to comfort, we're going to stop. And at least in situations that I've been involved with, getting clear on one of these 3 goals has been very helpful. You need to be aware of 2 different approaches to withdrawing mechanical ventilation. These have classically gone by the terms terminal extubation or terminal wean. They're defined as follows, that terminal extubation occurs after providing sedation, typically at least 1 hour's worth of whatever the patient has currently been receiving, and then removing the endotracheal tube and titrating additional sedation as necessary. Conversely, a terminal wean is where the endotracheal tube is left in place. And then the ventilator is turned to CPAP and room air over about a 5 to 10 minute period, sedation as necessary, and then the endotracheal tube is eventually removed, but only after the patient is apneic and unconscious. Now, this has been studied, and it turns out that most intensivists use only one or the other approach. And it depends very much on how you were trained. So if you're a neonatologist, you exclusively do terminal extubation. Pediatricians, mostly terminal extubation. Internists, a bit of a mix. Anesthesiologists and surgeons, solely terminal weans. And any time you see a practice fall out along specialty lines like that, it should be an indication that maybe something's wrong here. And my suggestion would be that, these have different advantages and disadvantages. Primarily with terminal extubation, you get rid of the plastic from the patient's face, allowing a more natural interaction with the family at the end of life. Whereas with the terminal wean, you keep the tube in, you maintain a patent airway, and so you avoid problems with upper airway obstruction. And I won't go into this anymore, but I think being skillful at both of these approaches to withdrawing a ventilator and then applying them where they make the most sense is something that we should aspire to. In any case, I would ask you, when you talk to families about what's going on, avoid using the term agonal respirations. It's something that we use all the time with each other. We know what we mean. But think about how that sounds to a family member. Obviously it implies the patient must be in agony. And that's not what we mean by it. But, snoring respirations, obstructed respirations, think about maybe using different words for that. I'm going to use a case here for a moment, and it's a pediatric case, but I think the issues are broadly generalizable, and I use it because it's a real case. This is a case that occurred in the ICU at University of California, San Francisco a few years ago, and was in the papers. It involved a 9-year-old boy who underwent facial surgery for mandibular hypoplasia. The anesthesiologist could not ventilate after induction of anesthesia, and the patient had a cardiac arrest. The child was successfully resuscitated but sustained very severe brain damage. After 2 weeks in the ICU, he remained dependent upon mechanical ventilation. He was unresponsive, but not brain dead. And after many meetings between his parents and the clinicians, they agreed to withdraw the ventilator and allow him to die. So a tragic case, but not an uncommon kind of case for us in intensive care. So I'm going to give you 5 different ways that this case could end. And I predict there's going to, some of them you're going to think are a little bit ridiculous and everything else, which is probably good. But I want to tell you, I work a lot in this field. All 5 of these happen around the country on a regular basis. So these are not ridiculous in terms of what actual practice is like. So ending number 1, the endotracheal tube is removed. The patient develops gasping respirations 8 times a minute and appears to be struggling. His mother pleads, "Can't you do something?" But the physician refuses, saying it would be unethical to give him anything that might speed up his death. Speeding up death is euthanasia, after all. That's illegal. And after about 8 hours, he has a cardiopulmonary arrest and dies. In ending 2, the tube is removed, gasping respiration, struggling. Physician gives a dose of morphine without much effect. Mother says, "Can't you do something?" Physician gives a large bolus of potassium chloride, leading to immediate cardiac arrest. So you're all twittering, I know, but that is what happened at UCSF. Okay, this is the true story from UCSF. The next one, ending 3, is a case that I am aware of from Dallas, from an ICU in Dallas. The physician administers morphine, 2 grams, not milligrams, intravenously. The tube is removed. The patient does not make any respiratory effort, appears peaceful, and is pronounced dead 5 minutes later. Ending 4, the physician administers a dose of morphine followed by pancuronium, 20 milligrams IV. The tube is removed. The patient does not make any respiratory effort, appears peaceful, and pronounced dead 5 minutes later. Again, twitters, I know, but this has happened in my intensive care unit, and I'll tell you I know of at least 4 or 5 cases in the last year, and I'll tell you about one towards the end, a specific case. And then ending 5, the endotracheal tube is removed, gasping respiration, struggling. Doses of morphine in standard pediatric doses every 5 to 30 minutes, titrated to the patient's comfort, and after about 2 hours, the patient has a bradycardic arrest and dies. So we've got the 5 endings here. No morphine, morphine followed by potassium chloride, the large bolus of morphine, the neuromuscular blocking agent, or the titrate administration of morphine. So I'd ask you which one you would prefer, A through E. And the answer is, I thought I saw it there briefly. And okay, so now this is interesting, and I want to point out. Now, I knew that you would all do this, but I want to say a word about it. First of all, I think that E is fortunately what we are commonly doing in ICUs today. But if I were to ask a young resident when a patient rolls in with sepsis, what should we do? They're going to give me the right answer. They're going to say fluids and pressors, It's one thing to give that answer because it's habit, it's what you're familiar with. It's another to give that answer because you really understand the physiology behind it. And then you recognize those situations where the common thing might not actually be the right thing. And I can tell you that in my ICU, while most everyone does E, they don't know why they do E. And when they are hit with an unusual situation, they're at risk for making the wrong choice. So I want to make sure you understand the reasoning behind E. I also want to point out that 6% of people chose C, the large bolus of morphine. And, think about that. If we were to take one of our beloved pets, as many of us I'm sure have done, to the vet, what happens in end-of-life care at the vet? Do they titrate in morphine? No. They do the equivalent of C, right? And so, I think that there's a wide divergence of opinion actually out there, and yet what is ethically and legally acceptable within our society is actually a fairly narrow window. And so I want to address that. And I want to do it in terms of explaining to you the doctrine of double effect. I'm sure most of you have heard of that. How many of you are familiar with this? Okay, it looks like maybe a little more than half. And it is important to know. We're going to talk about its application here to end-of-life care, but it gets applied to all sorts of ethical questions. It's a big issue in the ethics of war, for example, terror bombing and tactical bombing, that sort of thing. It applies to a situation where there's an act which has a good effect and a bad effect, hence double effect, and where, in this case, we're going to talk about giving morphine, where the good effect is relieving pain, and the bad effect is speeding up death. Now, right here, you can see the controversy is that probably at least a few of us and a number of people in society would say, well, speeding up death isn't always a bad thing. Sometimes it can be a blessing. Okay? And so I want to acknowledge that there's this difference of opinion among us. And yet, since euthanasia is illegal in our country, and everywhere except for the Netherlands and Belgium, we're going to operate within a framework that assumes that speeding up death is a bad thing. And double effect has 5 requirements. First, that the act itself be morally good or neutral. Giving morphine is morally neutral. It's not good or bad in itself. It depends on the context. Second, that the good effect is what you are intending. You're intending to make the patient comfortable. The bad effect is merely foreseen. You understand the pharmacology of opioids. You know they cause respiratory depression. You know this patient is likely to die a little bit more quickly than they would otherwise. But it's not what you're intending. Fourth is that the bad effect cannot be the means to the good effect. And this is where the potassium chloride comes in. And I will say to you only a little bit facetiously that actually potassium chloride is a very good pain reliever, right? It causes sudden cardiac arrest, and that does relieve pain very quickly. And, I think most of us would agree that a V-fib arrest is not a bad way to die. I hope it doesn't happen to me anytime soon, but if that's what happens when the time comes, I'll be grateful. And so we can't say that potassium is bad in that sense, but the reason why it fails under double effect is because you don't get the good effect of the potassium chloride unless you go through the bad effect. It doesn't relieve your pain unless it kills you. So that's the problem there. And then the fifth requirement is called the proportionality requirement, which is that on balance, the good that you're trying to achieve must outweigh the bad that you're allowing to have happen. So imagine, for example, if we admit somebody to the ICU after an automobile accident and they've got broken bones and they're in a lot of pain, but we fully expect that they're going to recover and do well. Now, clearly in that situation, it would not be okay to start titrating in morphine until they have a respiratory arrest, stop breathing, and die. We would have to do something different in that case. We'd have to put them on a ventilator or treat them differently, or they'd have to just, suck up their pain or whatever. But it's different when we have somebody who's terminally ill. And here we're going to say that making them comfortable is more important than trying to avoid hastening their death. So that's how this falls out under double effect reasoning. And so, just to review, option number 1 was giving no morphine. Now, that's not related to double effect. That's related to the goals of medicine and our obligation to treat pain and suffering at the end of life. And I say it's a legal obligation up there, but in fact, only in some states. Just like many things that start off on the West Coast and move to the East, this is one of them. Physicians in Oregon have lost their license for not providing adequate pain medication to dying patients at the end of life. And in California, physicians have actually faced criminal prosecution under elder abuse statutes for not doing this. And I think that the trend is moving that way. So we do have an obligation to treat pain and suffering. So it's not number 1. The potassium we talked about, the good effect is achieved through the bad effect. The large bolus of morphine before extubation. Well, the problem was for this physician in Dallas that gave this is that the medical examiner took the case, and of course what medical examiners do is they drew blood levels for toxins and drugs, saw this very high level of morphine, said, wonder what that means. Passed the case on to the DA, the district attorney, and you know district attorneys are elected positions. And one way to get elected on a regular basis is to have your name in the newspaper every once in a while, and kind of a good case, patient in the ICU, dies, high morphine level. So the district attorney goes back to the physician and says, well, explain to me, what were you thinking here in giving this 2 grams of morphine? And you can see the physician's in an impossible situation. It's very hard to argue that in giving 2 grams, he was only intending to make the patient comfortable, since it's clearly, a dose that we would use for cardiac anesthesia. Neuromuscular blocking agent. Just at the beginning, of course, these agents have no analgesic properties, so we can't possibly say that it's being used with the intention of making the patient comfortable, since it doesn't do that. I'm going to come back to this in a moment. But finally, the right answer, which of course most of you knew, is the titrated administration of morphine, because it clearly shows the intention to relieve suffering. I want to emphasize there's no maximal dose. There's nothing intrinsically wrong with the 2 grams that the physician gave in Dallas. In rare circumstances, it might be the right dose if the patient is highly tolerant to opioids. The only thing was you'd have to say there was a reason why it was necessary to make the patient comfortable. And also, although we are most comfortable using opioids and benzos in these situations, you can use anything you want, right? And I think, I'm frequently using propofol in these situations now because it gives me a very fast, reliable response. So don't feel like certain drugs are off the table. It's all available to you. Now, I've been pounding on this rather hard because I want to emphasize to you that this is a case where the ethics maps perfectly with the law. So this is a quote from our former Chief Justice Rehnquist, a Supreme Court case, where he wrote, "It is widely recognized that the provision of pain medication is ethically and professionally acceptable, even when the treatment may hasten the patient's death, if the medication is intended to alleviate pain and severe discomfort, not to cause death." Now, he doesn't use the term double effect in here because double effect is a philosophical term. But I think you'll agree if you were to try to summarize that diagram I showed you in a sentence, you couldn't do a better job than he did. So if you understand double effect, you practice under double effect, you will always be in line with the law. Paralytic agents. I want to mention this to you because I think it's a real pitfall. This is a real case, an elderly, terminally ill woman in an ICU. It's an ICU that all of you would know the name of, and it involved a surgeon that I know many of you would recognize the name of. And she'd been in the ICU for 10 weeks, had multiple failed weaning attempts. The family and the staff agreed to withdraw the ventilator. This physician, a surgeon, and gave her 2 doses of morphine, 5 milligrams, along with 10 milligrams of vecuronium. As he wrote later in documents, he said he did this so the patient would not appear to be in distress as the ventilator was withdrawn. The family was very satisfied with the dying process, and some weeks later, some other clinician reported the case to hospital administration. His clinical privileges were immediately suspended. The case was reported to the district attorney for homicide investigation. It was reported to the state medical board with regard to whether his license should be revoked, as well as to the hospital board as to whether he should lose his hospital privileges. I can tell you that after about 9 months and many, many thousands of dollars, all of this was resolved. He was allowed to practice with letters of disciplinary action, probation, etc. But this is the kind of thing that can happen when you're working in an ICU. You don't clearly understand the principles, maybe operating out of habit or whatever. You do something that seems like it might be a good idea in the moment, but really isn't. And, it just leads to this kind of torture. And nobody wants to go through this. So here's what I want to say about paralytic agents, because this happens all the time, is never, ever, ever give paralytic agents during the dying process to patients who have not already been receiving them. But we do know that some of our patients need them therapeutically to tolerate high ventilator settings or the like. So in general, when patients have been receiving paralytics for therapeutic reasons and you decide to withdraw life support, it should be delayed until the paralysis has worn off or been reversed. That is the cleanest way to deal with it. However, we realize that that's often not practical. And so in the guidelines for end-of-life care that we've written in their SECM guidelines, they're published in Critical Care Medicine, this is the paragraph that we wrote about that situation. We said when waiting for the paralytics to go away would require an unacceptable delay in withdrawal of life support, then withdrawal may proceed with careful attention to the patient's comfort. So this is in the guidelines from your professional society. However, I do want to say that this remains controversial. And there's a number of prominent ICU clinicians who do continue to believe that it's always unethical to withdraw ventilation from a patient who is paralyzed, and perhaps district attorneys who have the same view of it. So, I would warn you about this. I can tell you that in my practice, we do, if it's not going to be prompt in order to be able to let the neuromuscular blocking agents wear off, we do proceed with withdrawal of life support despite paralysis and write a note showing that we've thought the process through. Okay, a couple of pearls about this. Clearly document and verbalize your intentions. Your goal is to provide comfort, not to hasten death. Use the language of intentions when you talk to your nurses, your colleagues, yourself, when you write in the medical record. Use that language. Demonstrate your intentions with your actions. The one word to highlight here in yellow is titration, because titration shows that you are interacting with what you're seeing with the patient in terms of what you're doing. So there's a dynamic process there. One caveat to that is that if you're going to extubate a patient, then anticipatory dosing with an hour or two worth of what they've already been getting is appropriate. You're going to take a patient who's comfortable on a ventilator, you're suddenly going to remove the endotracheal tube, they're suddenly going to have a spike in dyspnea. It's appropriate to pre-treat them for that. That's called anticipatory dosing. Be prepared for the request afterwards when that patient keeps on breathing, please, can't we just get this over with? If you haven't been asked that yet, you probably will at some point in your career. Emotions run high in these situations. You need to have the right answer, which is we will do absolutely everything necessary without limit to keep your loved one comfortable. Anything that's necessary we will do, but we cannot go beyond what it takes to keep them comfortable. And then finally, document what you give. Horrible to get caught with a blood level for a barbiturate when you didn't document that you'd given the pentothal or whatever. A lot of explaining to do. You don't want to be in that situation. I think a lot of people feel like we border on euthanasia in what we do in the ICU. I really don't think so. We should be able to publish what we do on the front page of the New York Times and be proud of it. So document what you're doing. Last topic, brain death and organ donation. So let's do our final case number 4 here. A 25-year-old is admitted to the ICU after an MVA with severe closed head injury. After 24 hours, he has no detectable neurological function and a brain death exam is performed. At the time of the exam, he has not received any sedating medications. He has no metabolic abnormalities, normothermic, normotensive, and a 95% oxygen saturation on the ventilator. He does not respond to deep sternal rub. He has no pupillary, corneal, vestibular, or pharyngeal reflexes. He does, however, have spinal reflexes in his extremities. During the apnea test, he has ineffective respiratory effort with very small tidal volumes at a rate of maybe 2 or 3 a minute. A blood gas confirms that the PCO2 is greater than 60. So the questions, which of these is correct? At the completion of this testing, the patient can be diagnosed as brain dead. B, a confirmatory test such as a flow scan should be obtained to confirm the diagnosis of brain death. C, the brain death exam should be repeated in 6 to 12 hours to confirm the diagnosis. D, he is not brain dead because he has persistent spinal reflexes. E, he is not brain dead because he has persistent respiratory effort. So there you go. Okay, a little bit of spread, but E is still the correct answer. Now let me go through this and explain to you why. So he is not brain dead because he has persistent respiratory effort. So our brain death law in the United States is the Uniform Determination of Death Act from 1981. You can see it's very short. It says an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brain stem, is dead. Okay, that's all the law says. There's no single standard out there for determining brain death. Hospital policies vary. There's a number of consensus statements that vary, but they're all pretty much the same. So let me go over with you the key features. So you want to show that all brain functions have ceased. That's the left-hand column. And you want to show that it's irreversible. So if you think of the central nervous system as having three main components, the cerebrum, the upper brain, the brain stem, and the spinal cord, first of all, we want to show that the cerebrum is not functioning. Now, we don't really have sophisticated testing for this. It's basically a matter of just showing that the patient's in a coma. They're not responsive, they're not receptive, nothing's going in, nothing seems to be coming out. Our testing for brainstem function is a little bit more technical. Right? So we go through the list there, the pupillary light with the flashlight, the corneal test with the cotton swab on the cornea, oculocephalic, the doll's eyes test, moving the head back and forth, oculovestibular, 50 cc's of ice water into each ear canal, oropharyngeal reflex, either a Q-tip to the back of the pharynx through the nose or a suction catheter down the endotracheal tube, do the apnea test, which I'll mention in a moment. In particular, the patient does not have to have the loss of spinal cord reflexes. And this leads to an interesting phenomenon, which has been called the Lazarus sign. Often occurs during the apnea test. Sometimes very dramatic. Sometimes patients literally sitting up in bed with, this kind of emotion. So it doesn't mean that the patient's not brain dead, but it may factor into your decision of whether to have the family at the bedside when you do the testing. Because, some clinicians want the family to be there to see that the patient's not breathing. On the other hand, if you start to have a lot of spinal movements, it can be challenging to explain to the family why this person who's moving around on the bed is actually dead. So, your choice, but think about the implications. Next, the cause must be known and must be sufficient to explain the findings. If not, you need confirmatory tests. This is often overlooked. Quick example, a child I had a few years ago with an MAO overdose in our ICU met all of the criteria for brain death, all of them. And there was talk. She was brain dead. But her CT scan was normal. We didn't have an explanation for why she looked that way. If you don't have a plausible explanation for why the patient looks like this, don't declare them brain dead. Because more often than not, as in this case, it's a drug overdose with something that you're not able to detect. And when it wears off, the patient's going to be fine. You do want to rule out intoxication with the drugs that we can test for, rule out hypothermia and shock, since those can depress neurological function. And then just to be sure, we observe these patients for 6 to 24 hours. The apnea test needs to be done very carefully. The goal is to show that there's no respiratory activity with a PCO2 greater than 60 in the absence of hypoxia or hypotension. You typically start from a normal PCO2. More of an issue used to be when we used to hyperventilate these patients. Now we keep them basically normal carbic anyway. You pre-oxygenate with 100% oxygen, and then you maintain continuous flow of oxygen through the endotracheal tube to provide apneic oxygenation. Just a quick pitfall here. The safest way to do this is by hooking them up to an anesthesia bag and turn the flow up to like 10 liters or so. The pitfall is on many ventilators, if you just turn it to CPAP, the ventilators are designed not to waste oxygen, and so they don't deliver oxygen unless the patient is breathing. So you won't get a continuous flow of oxygen by the endotracheal tube. You won't have apneic oxygenation occur. You observe for respiratory movements. If the patient makes any respiratory movement at all, The test is done. They are not brain dead. It doesn't have to be effective. You draw a blood gas and resume ventilation after 10 minutes because we know that CO2 rises at about 3 torr a minute in an apneic patient, so that will give you enough time to get above 60, or if the patient becomes desaturated or hypotensive because the test is no longer valid. And we don't need to do flow studies as long as all this is met. We do flow studies when we can't do this, such as, for example, if the patient has had sedatives, which make it impossible for us to do this valid test at the bedside. Okay, so that's why the patient here is not brain dead. It's because he has persistent respiratory effort. None of the other issues are relevant. Any respiratory effort rules out the diagnosis of brain death. Spinal reflexes are not inconsistent with brain death. A flow study is irrelevant if the exam is not consistent with brain death. You have to have the exam first, then the flow study. And if the exam had been consistent with brain death, then a repeat exam in 6 to 12 hours would have been appropriate. Okay, a couple little caveats about this. Remember that the patient is declared dead and the death certificate is filled out at the time that you complete testing, not when the organs are procured. So a number of times now I've had situations where we've diagnosed brain death on a Tuesday, the patient went down for organ procurement on a Wednesday, and the family came back to me and said, Dr. Trug, you made a mistake on the death certificate. Family didn't understand that death was declared at the time we completed the testing, not when the organs were removed. Patients need to go to the operating room with the completed death certificate on the chart. Words to avoid: don't talk about withdrawing life-sustaining treatment after you've diagnosed brain death. It's no longer life-sustaining treatment. Talk about withdrawing the ventilator or whatever. Don't use the word harvesting organs. Think about how that sounds for families again. We harvest crops. We harvest, wheat and corn. We don't harvest people. Talk about procuring organs, recovering the organs. I think it's easier for families to hear in such a difficult time. And then finally, just a word about organ transplants and autopsies. You know now that all deaths and impending deaths must be reported to your regional organ procurement organization. You are audited on this, and your ICUs are scored on this. It's a very big deal. And the reason why they say impending deaths is now to cover the practice of DCD. And then finally, autopsies. You know that all states have criteria for cases that must be reported to the medical examiner. You need to know what those are so you don't mess that up. Otherwise, the autopsy should be requested by a physician who's involved in the care of the patient. So, whirlwind tour. Thank you for your attention. I know that's a lot to cover. I appreciate it.